Hello, good evening, everyone. We are going to start in about 2 minutes, but let me first give a preamble for today's uh, SWACC seminar. First, I want to invite the audience that has logged in already. We have about 16 members, but I don't think we shall wait for the others since we may not have a lot of time. They'll join us as we go along. So what I'll do is to just give a quick preamble and introduce the various speakers for today's talk. As you can see on your screens, it's really going to be about the bugs and the lungs. We're still in the theme of pulmonary madness, and we're going to have talks that span this. And basically, for the past couple of weeks, we've been looking at the lung in critical care. So we hold these seminars every Friday for those who are joining for the first time, and they're basically focused on anesthesia and critical care. And for the first couple of probably for the next couple of months, it's going to be largely critical care topics that we'll be tackling, and we invite um, different specialists in the various fields that feed into critical care to weigh in on various aspects. We've had radiologists, surgeons, and we're going to have pulmonary medicine experts. We're going to have microbiologists coming in. So as you remember before, that was last week, we had the diseases of the pleural space in the ICU. Then we had to go through a clinical case presented by Dr. Melissa Sechito. And I remember this was Valentine's Day, so the audience was eager to get on with their Valentine's Day celebrations. We are glad that we got at least about 60 people attending. And then we listened to Dr. Priscilla Cheng, as well as Dr. Jimmy, the EM physician. He's a resident, actually, he's about to graduate. And then we also had input from thoracic, that was Dr. Setari, as well as the radiologist then. So today we are going to mostly focus on the infections, the bugs that happen in the lungs. So one of the most important things for us to remember here is that there are things that happen within the lungs that we have to appreciate that will potentially increase the risk of disease. And the lung, of course, is very much interactive with the heart. So the way the two organs function has a significant impact to how the other one will also function. So basically, within the diseases that occur in the pleural space, we have you could have air, water, or chyle, or pus, or blood. It may be an acute or a chronic process. It may be a simple, complicated issue. It could be life-threatening, as in tension pneumothorax, for example. And then, of course, we have to appreciate that in various cases, we may have limitation with diagnostics. And however, at the end of the day, we have to use what we have, especially with the clinical acumen, to sort of decipher what could be the disease. And then, of course, management could entail a couple of various approaches, including watchful waiting, considering medication to manage some of the complications that could arise. It could entail drainage in some scenarios, depending on the quantities. And then it could require interventional approach that may allow us to seal off the pleural space, as well as treating the underlying disease. So all these were covered in the previous week's SWACCS seminar, and you can find the video on YouTube at Anesthesia UG. It's available. So today, the major aspect for this, for today's talk is really going to focus on the bugs and the lungs. And I want us to pay close attention, because these are some of the things that we probably meet and encounter quite frequently. And we shall start off with a case scenario. Today, Dr. Rasmus is a little delayed in the OR, but he'll be joining us. So I will kick us off I'm the mentor for this Friday, and we shall be hearing from Dr. Rasmus once is online, and we'll take on the moderation. We've been swinging between him moderating and myself moderating when we have various mentors. So today's talk, today's SWACCS is going to really be focusing, like I said, on bugs and the lung. And Dr. Patrick Samakula is going to kick us off with a clinical case, and he's a second-year resident in anesthesia and critical care. And then Dr. Charles Emuduko is a third-year resident, who will take us through community-acquired pneumonia and hospital-acquired pneumonia. And then Dr. Lydia Chienji will take us to the bugs and the lung in HIV patient. And then we shall wrap it off with the talks from Dr. Daniel Mwanda, who is a pharmacist and an expert in antimicrobial therapy in lung infections, weighing in on the approaches that can be used considering local sensitivity patterns, as well as where you do not have local sensitivity patterns, what would be the options of antimicrobial therapy in those categories. So a couple of rules. We are going to mute, and I'll also control the mute function on my side. So only those who have co-host privileges will be able to unmute themselves. Please feel free to send your questions through the chat so that the speakers can attend to them as soon as they are done giving their talks. However, in case you wish to ask a question in person, please just tap the raise hand button, and then we shall allow you to unmute and speak to the presenters directly. At the end of this, as the mentor, I'll give a wrap up. Usually it doesn't take long, about 5 to 10 minutes max, to put everything in perspective. So without further ado, I will invite Dr. Patrick Samakula. He's a second-year resident in anesthesia and critical care at Makerere University College of Health Sciences to present the clinical case. Over to you, Patrick.
Good evening, everyone. I hope I'm audible. So I was given the privilege to present a case in this week's Pulmonary Madness series. It's about the lungs and the bugs. So let's get right into it. All right. So this was a 38-year-old male who was a referral from a PNFP. He had worsening shortness of breath for 5 days, malaise, and generalized body weakness. This person had developed a dry cough that had slowly progressed into increasing shortness of breath with a low SpO2 of ranging from 84 to 88. Remarkably, in the past medical history, was previously managed for deep venous thrombosis 2 years ago and had completed DOAC treatment for 6 months ago. He had no known drug allergies, and the social history had recent air travel to Europe. On the assessment, the patient was in severe respiratory distress, the respiratory rate of 35 breaths per minute, 35 breaths per minute. The SpO2 on non-rebreather at 15 liters per minute was low. So our heart rate was also high, at a tachycardia of 135, blood pressure of 140 out of 85, and the temperature was normal 36.7. So at that point of assessment, the patient was suspected to have submassive PE with hypoxemia. D-dimers were done and they were elevated, 5,000. At that time, the CT pulmonary angiogram could not be done because of the severe clinical state the patient was in. So the recommendation was ICU admission for partial thrombolysis under close monitoring. Now, on admission to the ICU, on assessment, patient was was alert, but was unable to complete sentences. And breathing, they were in severe respiratory distress, the respiratory rate of 48 breaths per minute. The SpO2 was 78 on non-rebreather mask, 15 liters per minute with a collapsing reservoir bag. On palpation, the midline tract, they had a midline trachea with bilateral equal chest rise. And nose auscultation, they had clear breath sounds, but with reduced air entry at the bases. So the plan at that time was to initiate invasive mechanical ventilation, and that was based on the refractory acute hypoxemic respiratory failure with severe respiratory distress. Also, a chest X-ray was also recommended, and a baseline ABG to assess the oxygenation and ventilation status. Our ABG was done and showed a picture of our metabolic acidosis. A lactate of 3.5. Yes. On the circulation, the peripheries were warm. Capillary fill time was 2 seconds. They had a normal volume pulse, but they were tachycardic. The pulse rate was 145 beats per minute. The blood pressure was 150 out of 80. JVP was not visibly elevated. Heart sounds 1 and 2 had no additional sounds. And they had a peripheral IV line, 20 gauge in the right hand. It was running a Ringer's lactate drip. So the plan was to place a large bore peripheral IV line and to draw samples for routine hematology, chemistry, HIV screening, hepatitis B surface antigen, and hepatitis C antibody, and have a slow drip infusion running. On the disability, the GCS was 14 to 15. Pupils were equal and reactive to light, 3 millimeters. There were no visible focal neurological deficits. Our random blood sugar was 11.2. And the plan at that time was to monitor the GCS. On exposure, the patient was morbidly obese. However, they didn't have any fevers and there were no overt lesions seen as well. So a problem list was drawn and with plans attached to it. Our first problem was a severe acute hypoxemic respiratory failure with respiratory fatigue. The plan that was done was invasive mechanical ventilation was initiated. The mode was PRVC with a tidal volume of 480, respiratory rate of 25, a PIP of 8, and an FiO2 of 100%. Significantly, during intubation, there was a rapid per-intubation desaturation. Our lowest SpO2 was 35, and the highest we could attain was 71%. When they placed the patient on mechanical ventilation, they had high airway pressures with a plateau pressure of 38, and they also had a poor static compliance of 15. That plan was to increase the PIP to 10 and deeply sedate the patient with midazolam and fentanyl and paralyze them with cisatracurium to help deal with the distress. Our second major problem was shock. And at that time, we were not sure of whether it was vasodilatory or hypovolemic. And vasopressor support was initiated with norepinephrine at 0.1 micrograms per kg per minute and a fluid bolus of 500 mils, 30 minutes. And also to place central venous catheter immediately and to draw a sample for central venous circulation and run an ABG as well. So our third issue at that time was a massive PE. So we're querying a massive PE. So a bedside echo was, that was a plan to do a bedside echo to assess the right ventricle and the pulmonary artery and consider thrombolysis. They're also querying sepsis from community-acquired pneumonia. A septic screen was done Blood was taken off for cultures. Tracheal spirit also taken off, and urine. C-reactive protein was also ordered for, and antibiotics were initiated, cefotaxime and azithromycin. And also fast hugs and BID was also initiated. So after 2 hours, patient was reassessed, and the patient had slightly improved. The heart rate had gone down to 125. The blood pressures had also dropped 100 out of 60 on a norepinephrine infusion of 0.1 micrograms per kg per minute. Our SpO2 had improved to 85. The PEEP had been set to 10. Respiratory rate was 25 breaths per minute, and they were still afebrile. So the ABG that was done showed that they had a metabolic acidosis with a high lactate of 2.4 and a high AA gradient. The VBG showed our central venous saturation was reduced to 60% and the lactate of 3. Our CBC results showed leukocytosis of 14.2, a high CRP of 68 milligrams per liter, a low HB of 10.2, and patient was discovered to be seropositive HIV. Our chest ray that was carried out showed some hilar opacities, heterogeneous opacities, and that was a chest ray that was done. The interventions, again, another problem and plan sequelae was started, and our first problem was severe ARDS with low PF ratios, poor static compliance, and high airway pressures due to community-acquired pneumonia. So lung protective ventilation was initiated. They changed the setting from VC to PCV mode, and they targeted a driving pressure of 15 to 20, permissive hypercapnia with allowing the pH to go above 7.25, patch pressure of carbon dioxide to be around 55 to 60, target SpO2 be 88 to 92. And they also considered a recruitment maneuver if the lung was recruitable. Troning was also considered, but because of the morbid obesity and the difficulty in experience, it was not carried out. A conservative fluid therapy was also continued. For the problem of shock, they decided to maintain the norepinephrine infusion, to monitor the perfusion indices and keep the MAP above 65%, 65. Then for sepsis in immunosuppression, they were querying the cause of sepsis to be either bacterial, viral, or PJP. So plan was switch antibiotics to have anti-pseudo mono coverage. So cefotaxime was switched to cefepime, and those patient also started at high dose Septrin. Ganciclovir could have been started but was unavailable at that time, and also steroid was added, IV methylprednisolone. The immunosuppression, plan was to do a viral load and a CD4 count because this was an AT-naive patient. The family was updated. There was family conference. They were unaware of the serostatus, and also the primary physician was as well unaware. Between ICU day 1 and day 3, the severe RDS had improved. The static compliance and oxygenation had gotten better, with the maximum SpO2 that was achieved was 98. The PF ratios had improved to 150, and the driving pressures had reduced from 20 to 15. The lowest FiO2 that was put to maintain the oxygenation was 60%, and they set a PEEP of 10. They stopped paralysis and maintained deep sedation to reduce the work of breathing. For the vasodilatory shock, norepinephrine was weaned down. They reduced the dose to 0.07 micrograms per kg per minute, and the lactate had also dropped, and the highest lactate then was 2. The cultures didn't grow any bacteria. However, we still had the rising CRP. Our highest white blood cell count was 18, and neutrophilia of 88%. The CD4 count that was done was 20, and the viral load of 85,000. So our HB had also dropped to 8.5. So the plan was to monitor the HB and the hematocrit, and to consider transfusion if the HB drops below 8. So between ICU day 4 and 7, patient continued to improve, and the sedation was actually weaned down. They had low oxygen requirements, and all the lung mechanics had improved. And even the vasopressor support was weaned off. Our X-ray that was done during that time showed consolidations all over in both the lung fields, in both the lungs, and yes, there are bronchograms that could be seen in this image as well. Between ICU day 8 and 14, unfortunately, the patient developed ventilator-associated pneumonia with increasing FiO2 and PEEP requirements. They had worsening lung mechanics. The static compliance continued dropped again, and the high airway pressures developed. An ABG was done, and our lactate was very high of 7.5, and we had a severe respiratory acidosis. They also had high-grade fevers of 38.9. Our CRP was rising. So because of this, antifungals were added, voriconazole, a septic screen was repeated, meropenem and vancomycin were also added, and also high-dose septrin. The main issues were the respiratory acidosis, carbon dioxide retention, and the patient was also requiring high vasopressor support. Unfortunately, the patient sustained a cardiac arrest due to severe mixed acidosis, and CPR was initiated. However, ROSC was not achieved after 20 minutes. May he so rest in peace. When the septic screen results came back, they showed that the tracheoaspirate had multi-drug resistant Klebsiella pneumoniae. And that was our final chest X-ray. May God continue comforting the family of the patient. Thank you for listening.
All right, thank you very much, Dr. Patrick.
I was being heard.
Are there any questions from the audience? We have about 2-3 minutes to spare. If you have any questions, just raise your hand and then you can ask.
Yeah, I can't raise my hand. This is Dr. Lydia.
Yes,
About
Lydia,
the final results of the cultures. Were you able to get this before the patient succumbed, or the results delayed and you only obtained it after the patient had succumbed? Thank you. Did you hear the question? Thank you.
Patrick, did you hear the question? And Patrick, you're muted in case you're talking. Oh, Patrick. I think Patrick is probably okay. He's unmuted. I don't know if he's Patrick. Can you hear us?
I hand over to Dr. Cornelius to continue the moderation. Any questions are welcomed at this point.
I don't think Dr. Lydia had your question. What is your answer? Did you hear her question? Patrick. Okay, maybe I'll just make a submission so we can conclude on this. So the results of the septic screen came out, I think, about 2-3 days after the meropenem and Vanco had been started, but those are really preliminary, not giving us a full sensitivity pattern for the bugs. So most likely with a bug like pneumonia, or as we shall hear from Dr. Chance, it may not be very sensitive to carbapenems. So you need to have a full panel showing you the sensitivity profile for a bug like that. If it is Pseudomonas, the same category. So it can be pretty difficult if you don't have a full panel to be able to tell if the bug that you're dealing with will even respond to carbapenems. So I think the team escalating upwards towards carbapenems was the right move, but the risk that a bug like pneumonia may be resistant to them is also quite high. I hope that answers your question, Dr. Nachin.
Yes, thank you.
You're welcome. All right, Patrick, if you could stop sharing so we can move on to the next presenter. I will introduce the next presenter, and just give me a second. So our next presenter is a trainee in anesthesia and intensive care, and he's let me just show the slide so we can all put a face to the name. He's called Dr. Charles Emuduko, and Dr. Charles is a trainee is a third year resident, anesthesia and critical care. And he is going to talk about community and hospital-acquired pneumonia. As we all know, the name changed, I think about 5 or so years ago, from healthcare-acquired pneumonia to hospital-acquired pneumonia. So Dr. Charles Emuduko, I will hand over to you to share your slides and go through your presentation, at the end of which I hope that we will do a quick poll question from the audience to see if the audience grasps some of the things that you talked about, and we shall ask you to weigh in on the responses based on the audience's input. Thank you.
Yes, thank you, moderator, Dr. Cornelius. Yeah, our colleagues, Lucas, Dr. Cornelius has introduced me, so let me go straight to the talk. I hope I'm clear and audible.
Yes, you're clear and audible. Go ahead.
Okay, thank you. Yeah, so this is our lineup. So we are going to look at the introduction, classification, epidemiology, risk factors, and etiological agents, pathogenesis, and focus on really the new concepts, and diagnosis, treatment considerations, and complications and preventions. Well, and my references. Yes, so as we all know, pneumonia is inflammation and consolidation of lung tissue, most cases caused by an infectious agent. Yeah, as you can see there, we have inflammation of the alveoli and then deposition of debris there. So, and as you can see there, this affects gaseous exchange. So classification. So pneumonia is has many ways it is classified. So classification can be according to the site of acquisition, can be according to the etiological agent, can be according to severity. Okay, but today we are going to really focus on the classification according to the site of acquisition, since it is the one that we mostly use for clinical purposes in terms of care for the patient and making decisions, the clinical decisions. So the classification according to a site of acquisition, we have community acquired pneumonia, basically acute infection of the pulmonary parenchyma acquired outside healthcare settings. Then we have hospital acquired pneumonia. So pneumonia acquired 48 and above hours after hospital admission. Okay, so this can be non-ventilator associated hospital acquired pneumonia. So in most cases, this is pneumonia acquired within the hospital, but is non-ventilator related. Then the ventilator associated one is for those patients who are intubated or on mechanical ventilation. Yeah, so my colleague Patrick has presented a very good case. Yeah, so that patient was initially referred to receive a critical care from a peripheral center. So it is a bit difficult for us to possibly classify whether that patient had community-acquired pneumonia or it was hospital-acquired, since that patient was initially in a health facility before he or she was referred to the ICU at the other facility where she was managed. So, well, so, but it is important to classify because that is going to be very key in decision making in terms of antimicrobial selection and all that. Then epidemiology. I'll start this talk on epidemiology by paying tribute to the legendary Sir William Osler, legendary physician, who wrote in his book, Principles and Practice of Medicine in 1901, and was quoted, he said that pneumonia is the captain of men of death, the old man's friend. So during that period, many people, many seniors used to die because of pneumonia. And I think still it is still a great problem up to now. So let's see how it is in our generation. Here I have tables from WHO. WHO published this in 2021. The first table, you can see, so the top 10 leading causes of death globally. So the first table is for the global causes of death in 2021. I couldn't get the most recent one, so but I was able to get this one for 2021, which is not very far off, was at least within 5 years. So the leading cause of death was ischemic heart disease. COVID was second, a stroke, chronic obstructive pulmonary disease, COPD, And then a lower respiratory tract infection was number 5. So our interest is the lower respiratory tract infection, which is basically, in most cases, pneumonia, because it is acute bronchitis, bronchitis, and pneumonia. So, but the other two, in most cases, are self-limiting. So the biggest problem is normally the pneumonia. Yeah, so it was ranking number 5 globally in 2021. Yeah, now, but the very period in the low income countries where we fall, Uganda, you can see that pneumonia was ranked as, oh no, the low respiratory tract infections were ranked as the leading cause of death. So this is very huge for us. We still, I think, have a lot of work to do. So I think maybe these teachings we are having and possibly the socioeconomic transformation agenda might help us in the future to catch up with the other first world, where the cardiovascular, the non-communicable diseases are the leading cause of death. So, and also this projection is, the last table is for the projection of mortality 2030. So, but you can see that lower respiratory tract infections are still up there and in position number 4. Yeah, so that shows that despite the advances we've had, and this is still a really big problem that requires us to continue really do a bit more to reduce this burden. When we come specifically to the pneumonias, the types, community-acquired pneumonia has an incidence of about 145 cases per 100,000 adults per year. For hospital-acquired is about 5 to 10 cases per 1,000 hospital admissions. And the mortality for CAP is 27 to 50%, short term and long term. And then the mortality for hospital-acquired pneumonia is 13 to 28% for ward hospital-acquired pneumonia, 15% for non-ventilator associated ICU hospital-acquired pneumonia, and 18 to 28% for ventilator-associated pneumonia. So as you can see, the mortality and then the mortality short-term and long-term is really high, that it goes to almost 50%, which is huge. Yes, now we'll look at the risk factors for acquiring this condition. For community-acquired pneumonia, extremes of age, that is the young, and then the senior citizens, 65 and above, and then the under 5s at a high risk. Then, of course, comorbidities, that is chronic respiratory disease, cardiovascular disease, liver disease, renal disease. All these conditions predispose one to having pneumonia. Toxic inhalations, not just only smoking, but obviously also pollution, which is, of course, a problem that is emerging in our country also. The other thing is alcohol misuse is also a big cause of community-acquired pneumonia. where many aspirate and get Klebsiella. Immune suppression, that is HIV, diabetes, steroid use, immune suppression from a treatment that is, for example, like patients who have received grafts. So all that predisposes people to community-acquired pneumonia. Viral respiratory infections, of course, those ones disrupt the host defenses and make it easier for a secondary infection to occur. The depressed consciousness, for whatever reason, stroke, all that can cause infection, community-acquired pneumonia. Institutionalization is also a risk factor where you can have overcrowding, okay, and that makes it easier to have these bugs spread. For hospital-acquired is a big one, ICU admission and intubation with mechanical ventilation, especially for ventilator-associated pneumonia. Elevated gastric pH, then antibiotic use, paralysis and deep sedation, multiple trauma, okay, chest and upper abdominal surgery. These ones make it difficult for one to have to clear either secretions well or to cough well and all that. Presence of intracranial pressure monitors. Yeah, so these ones you can have the infection hematogenously. Aspiration, poor oral hygiene, then multiple CVC placements are also a risk factor for pneumonia. The etiological agents for CAP and HAP, the most common for CAP are the strep and pneumonia. Then the influenza, Haemophilus influenzae, and then Moraxella catarrhalis, Klebsiella pneumoniae, the atypicals Mycoplasma pneumoniae, Legionella pneumoniae, Chlamydia pneumoniae, and of course the respiratory viruses, where we also have the SARS-CoV. The less common for CAP are the enteric gram-negative bacilli, Pseudomonas aeruginosa, and then Staph aureus. While for hospital-acquired, the most common are the enteric gram-negative bacilli, Pseudomonas, and then Staph aureus. And then the less common are Acinetobacter baumannii, Stenotrophomonas maltophilia, and Candida species. Yeah, now the big problem with the bugs that normally cause HAP is that these bugs are normally multi-drug resistant bugs, which are normally difficult and challenging to manage. The pathogenesis, traditionally, as you can see, the concept has been that for one to get pneumonia, you have inhalation of droplets that contain pathogens. Those pathogens colonize the nasopharynx. Then by microaspirations, those pathogens arrive in the alveoli. And in the alveoli, they have uncontrolled multiplication and local production of cytokines. And then, of course, you have that inflammation, and then you have recruitment of neutrophils, and then introduction of cytokines into the circulation. So you have an exudate into the alveolar space that has all those cells with the pathogens, And of course, that accumulates and blocks the surfaces for gas exchange. So initially, it was thought that the alveoli are sterile. Yeah, but the new concept is that the alveoli, the alveoli or the alveoli are not sterile. So they are lung. There is a lung microbiome. Okay, so they are microorganisms that are residents of the alveoli. So they do interact with the host defenses and with each other to ensure that a balance is maintained, an equilibrium, none overgrows more than the other. And these microorganisms also help to modulate sometimes the response of the host to pathogens that may want to also grow within the alveoli. Yeah, so, but things like that can disrupt this symbiotic relationship of the lung microbiome and the host defenses normally lead to the acquisition of these bugs overgrowing, and then causing disease. So, for example, smoking and toxic inhalations, yeah, that can disrupt the microbiome, the lung microbiome, diseases like COPD, diseases like asthma. So they disrupt that symbiosis, and either destroy some of these organisms and disrupt that balance. Those very organisms may overgrow and cause disease, or when the other pathogens come in, they can easily have an easy way to also grow and multiply in the lung and cause disease. So the lung microbiome generally consists of anaerobes that are similar to those in the oral cavity. So we have Prevotella, we have Veillonella, microaerophilic strep. So those are the ones, those are the commensals in the alveoli that try to maintain that interaction between the lung microbiome and then the host, which is protective. Then the other concept I wanted to also bring to our attention is now it has been found that these microorganisms that cause pneumonia can directly or indirectly cause myocardial injury. And so, for example, the virulence factor pneumolysine that is released by pneumococci can cause necroptosis of the myocytes, and that can cause cardiovascular damage, or that can damage the heart. And with time, one can have cardiovascular events, okay, short term or long term. So it has been found that many of these patients who get community-acquired pneumonia also get cardiovascular events, and it is thought that there are some. It is one of the things that is a major contributor of long-term mortality in this patient group. Diagnosis. So we'll look at diagnosis in a clinical way. That is clinical criteria. Then we also look at it radiologically and microbiologically. Clinically, you start suspecting one has a community-acquired pneumonia when there is presence of acute symptoms less than 7 or by 7 or less than 7 days. symptoms of lower respiratory tract infection, for example, cough, expectoration, fever, chills, dyspnea, and the presence of a new infiltrate on a chest X-ray. Whereas for, so this is the same for hospital-acquired pneumonia, that is a non-ventilator associated pneumonia. So the difference is that it occurs 78 hours after admission. But for ventilator-associated pneumonia, we usually suspect it when the patient has symptoms of fever or hypothermia, leukocytosis or leukopenia, and you're having evidence of purulent secretions in the ETT or tracheostomy aspirates. And then a new or progressive lung infiltrate, because the patient might have come with a lung already with infiltrates in the lungs from maybe a community-acquired pneumonia or from any other cause. But when you see a new infiltrates and then worsening, and then you can also suspect hospital-acquired pneumonia. For example, ventilator-associated pneumonia. For example, our patient initially came in and then was being managed for the community-acquired pneumonia and was improving. Yeah, but after a few days in ICU while intubated, as he was responding, that is the cardiovascular-wise, respiratory-wise, he suddenly deteriorated and then developed, the symptoms started worsening. Okay, so, and even the X-ray findings were worsening, so showing that there were new infiltrates coming in. So meaning that the patient got ventilator-associated pneumonia, which unfortunately he was he was unable to survive the episode of ventilator-associated pneumonia. So radiologically, I'm not going to comment a lot about the radiological findings because I think we have a session on the radiological findings on pneumonia, so chest infections particularly. So, but briefly, for community-acquired pneumonia, so a chest X-ray is essential. So you can see hematogenous opacities or heterogeneous opacities. Okay, so you can also see the other complications, pleural effusion and all that. Then the other modality is the high resolution chest CT, which is more sensitive than the chest X-ray. And I saw something like that. A CT can pick up to 30% of pneumonias that an X-ray has failed to pick up. The other modality that we are now using more often is the lung ultrasound, which is very important for hospital-acquired pneumonia, particularly ventilator-associated pneumonia. So because it is more specific and more sensitive and specific compared to the chest X-ray. But I think Dr. Juliet will tell us more about the radiological diagnosis and which modality performs in which way, which one is best. So for microbiological criteria, so for community-acquired pneumonia, of course, if a patient can expectorate and can give you a good quality sputum, yeah, that is good and would be at the best. So we'll do a quick gram stain, which is important, that can help you even make decisions in terms of empirical antibiotics. Then the other thing we can do a ZN on it. We can do cultures and sensitivity. Then also we can take off samples from the nasopharyngeal swabs, which are very important for the diagnosis of respiratory viruses in case the patient is having a respiratory virus causing the pneumonia. Yes, then the other thing also that these PCR tests are really quick and can help also guide in terms of antimicrobial selection, as we'll see when we reach that point. Then blood culture. So we can also do a blood culture, but the blood cultures are the most unyielding in pneumonia. Yeah, so, but we can do, especially for patients who are showing systemic signs, we can do the blood cultures and try to isolate the organisms from blood. Yeah, but in most cases, they're unyielding. We can take off urine. Urine is important in the diagnosis of Legionella, which is a big problem that causes atypical pneumonia. So the antigen test for Legionella can be done on urine, and also we can do the pneumococcal test on urine yeah. Then the other sample that can also be done if we go invasive, we can do the bronchoalveolar lavage, and then we can do all those tests where we can do the gram stain, we can do cultures, we can do PCR, molecular test PCR, and so forth. For hospital-acquired pneumonia, that is non-ventilator associated, and the patient doesn't have, is not instrumented, the airway is not instrumented, and can give you sputum and nasopharyngeal swabs and all. We can also do take off samples like sputum, the nasopharyngeal swab. But if the patient is instrumented, that is has an ETT or a tracheostomy, yeah, tracheoaspirates is the sample, and then all the bronchoalveolar lavage. Yeah, so commonly for ventilator-associated pneumonia, it is tracheoaspirates, and if we don't get the information we want, we can go invasive and do a bronchoalveolar lavage, and then do the cultures, do the gram stain, the cultures and all. So, but as we do these tests, it is very important to try and distinguish between colonization and infection. Sometimes it is difficult, but it is important we try to distinguish between colonization and infection. Then treatment considerations. Yes, so number one is I'm going to really focus on a critical pneumonia patients whom we normally who normally require critical care. Yeah, so triage is important. So sometimes, in most cases, we receive these patients in the ICU, okay, but sometimes we are called to the floors to assess these patients and make decision whether they need a critical care and should be managed in ICU or not. So we'll look at some few tools that guide in terms of making this decision. Then number two, resuscitation. As we know, in critical care or acute care, ABCD approach is always king in making sure that we stabilize these patients. Then the other consideration is the choice, if we have stabilized the patient, the choice of the initial antimicrobial therapy, the empirical regimen, that is an important decision. And also the timing of initiating this regimen, and then tailoring therapy, where the decision to de-escalate or escalate, and then duration of antimicrobial therapy. Then switching to orals. Okay, then obviously the first hugs in bed for housekeeping for all patients who are in ICU, or patients who are critically ill. So we'll start with triage. So the two, we have like 3 tools here, which were validated. One of them is the CAB 65 scoring, where you can see the parameters are confusion, urea levels, respiratory rate, systolic blood pressure, and age, and each has one point. Okay, so and here we are guided on the score and then the risk of mortality and who to admit. For CAB score, if you use the CAB 65 score, so in most cases we consider admitting those who have a score of 4 to 5. Okay, so they probably in most cases have a confusion, their kidneys are starting to fail, the respiratory rate is high, they have a high work of breathing, and then they may be hypotensive, okay, might be senior citizens. So then for the other score is the pneumonia severity index that has more parameters, the demographic factors, coexisting illness, physical findings, and the laboratory and X-ray findings. Yeah, so with it, we tend to admit mostly patients in class 5, okay, with a high mortality risk of high 30-day mortality risk of about 27. Yes, then the American Thoracic Society and the Infectious Disease Society of America have a criteria also that guides, and it has the major and minor criteria. As you can see, the major is need for invasive mechanical ventilation, and then the patient who is with septic shock with a need for vasopressors. The major criteria is obvious, and in most cases, I think we receive our patients with the major criteria. Okay, so we are normally called to see patients that they already satisfy the major criteria. The minor criteria is respiratory rate, has the respiratory rate, the PCO, the PaO2, FiO2, the multilobar infiltrates, confusion, uremia, leukopenia, thrombocytopenia, hypothermia, hypotension. Okay, so for the minor criteria, a patient needs to satisfy at least 3 of them to be admitted to ICU. Yeah, so but this is these are the guidelines, but in practice, sometimes a judgment or the decision can come from other factors that may not be in this criteria. So when you assess the patient, you can sometimes admit them, not necessarily because the patients are fulfilling these criteria, but there are some other issues that you really see will require the patient to be managed in the ICU. Now, when we come to choose, let's say we've stabilized the patient, we've done our ABCDE approach, just like the patient who was presented. Yeah, so when the team received the patient, who my colleague Semakula has presented, they assessed the airway, and the patient's airway was initially, the patient was alert and the airway was okay. So then they went on to assess the breathing. So his oxygenation was poor. So the team decided to intubate and do mechanical ventilation. Then also the patient was while they were doing the intubation, the patient got hypotension, so which was suspected to be vasodilatory or due to intubation. So the team started vasopressors to support the cardiovascular system. Okay, yes. So and then continued the assessment accordingly and stabilized the patient. So as you saw, the patient was improving till he got another problem that really caused the issue, caused his demise. So ABCD approach to stabilize the patient first, then we can make the decision now on the antibiotic, on the initial empiric regimen, the definitive care. So what we consider, one is risk stratification for MDR. So in most cases, patients who come to us, they have critical pneumonia. They have a high likelihood of having MDR, multi-drug resistant organisms. That is the ESBLs, extended spectrum beta lactamases, and then CREs, the carbapenem resistant Enterobacteriaceae, of course, and then the notorious MASA, methicillin resistant Staphylococcus aureus. So patients who come to us and they are critical, we need to assess their risk for having these organisms, because it is very important in the decision on which initial regimen the patient is given. For community-acquired pneumonia, there are a number of risk factors, but I picked out the strongest for MASA and then Pseudomonas. And then these are known MASA colonization, then prior MASA infection. The other one, the third one, is detection of gram-positive cocci in clusters on a good quality sputum, gram stain. Okay, so yeah, so in most cases, obviously, we don't know colonization, the risk of colonization, but in some settings where MASA is a big problem and highly prevalent, some facilities do the screening of patients who are symptomatic, and then they do screen them for having MASA, can do nasal swabs, and then try to do cultures or molecular tests to confirm whether they are colonized by MASA. So in case that patient comes in and has that history, then obviously they are at high risk of having MASA as the cause of CAP. Okay, so the same applies with Pseudomonas. If a patient was screened before for Pseudomonas colonization, and then prior Pseudomonas infection, then also detection of gram-negative rods in good quality sputum, gram stain, and then hospitalization with receipt of IV antibiotics in the prior 3 months. So those are the strong risk factors for having MDR Pseudomonas. Yeah, so what I can comment here is that in most cases, we don't, whenever we take off our sample, we don't normally request for a gram stain, but gram stain is very important in making some of these decisions. So it is something we should make sure we take home. Yeah. So these tables, I adopted them from up to date. Yes. So for ventilator-associated pneumonia, the risk factors for MDR that is having the Pseudomonas MDR and other gram-negative bacilli and MRSA, receipt of IV antibiotic use within the previous 90 days, septic shock at the time of VAP, okay, ARDS preceding VAP, 5 days of hospitalization prior to the occurrence of VAP, then acute renal replacement therapy prior to VAP. So I think our patient in the earlier presentation, the case, I think he had these are 5. I think he had about 4 of these risk factors for having MDR pathogen as the cause of VAP. So, and I think that is why the team tried to really give antibiotics to try and cover for multi-drug resistant bugs. For non-VAP hospital-acquired pneumonia, the major risk factor is IV antibiotics within 90 days. Okay, so so basically here, if you have a patient and you suspect hospital-acquired pneumonia and they have had antibiotics given to them in the previous 90 days, then they are at high risk for these microorganisms. Even if you don't remember the other risk factors, at least let that be a take-home that patient who has received IV antibiotics within the past 90 days is at risk for these bugs. So we must handle accordingly. Yeah, so now how do we decide the initial regimen according to this risk stratification? Of course, there are other factors as we'll go through them, but the biggest one is in most cases this risk stratification, because we normally want to make a guess that is going to in most cases be the right one, because this patient is critically ill. You wouldn't want them to initially be on treatment that does not clear the microorganism, because that will just increase that one will just, the disease will just continue to progress. So you want to really make the best initial guess of the antimicrobial. So I know we have Dr. Dan is going to go through the antimicrobial therapy. Yeah, so I think I will comment a bit, a little on the decision here, or the choice, the clinical choice here, while starting patient on the antibiotic. So for community-acquired pneumonia, in most cases, for a patient who doesn't have risk factors for MRSA and Pseudomonas, we in most cases start with a 3rd-generation cephalosporin and cover them for atypical microorganisms. Either we give a microlide, azithromycin, or a quinolone, okay, levofloxacin or Cipro. So that is for a patient who doesn't have risk factors for Pseudomonas or MRSA. Now, if a patient has risk factors for Pseudomonas, okay, so we need to cover them and give them higher anti-Pseudomonal beta-lactams. So we either give piperacillin, tazobactam, or cefapine, or a carbapenem. Okay, yes. So, but it also depends on the local antibiogram. So it is important for a facility to have an antibiogram, but in most cases, our centers do not have these antibiograms. So we normally make decisions from adding up a lot of information. So if the patient,
Charles,
yes,
I'm sorry, I'm going to give you 5 minutes to wind up because I think a couple of these things are going to be covered later as well. So just grace through the remaining part of your presentation. Thank you.
Okay, thank you. Let me then move fast. So the other factors we consider are local antibiogram and guidelines, potential adverse effects of antimicrobial agents, then also potential drug interactions, then patients' severity of illness. Sometimes is also very important, as I noted earlier. Then the results of a good quality gram stain can guide on which empiric antibiotic to start with. Then also there are those quick PCR, especially multiplex PCR, if it is done and we get results quickly, can also help us guide. Yeah, sometimes our decision is hindered by availability of the drug or cost. For example, I don't know whether currently we have the newer beta-lactamase drugs that would help us with the carbapenem resistant Enterobacteriaceae. So that is also can affect the decision on what we start with. And of course, our clinicians' familiarity with the different antibiotics. So what is new? The other thing I think maybe my colleague will talk about it, that we can consider is, especially in these critically ill patients, is dose optimization by manipulating our pharmacokinetics and pharmacodynamics by either prolonging infusions of these drugs instead of giving intermittent boluses and prolonging their infusion. Giving prolonged infusions to increase the period at which these drugs are above the MIC, which can improve their bactericidal effect. The other also thing is, but also that depends on the availability of the pumps and whatsoever, logistics and all that. The other also thing is aerosolized antibiotics, something that is still being studied. This tries to deliver a higher concentration of the drugs at the site where we think the problem is. But of course, it is not generally done because it has also some drawbacks and the studies are still ongoing. And so what is possibly in the pipelines? Yeah, so studies are looking in the direction of immunologics. Molecules that can that are either monoclonal antibodies that can be used to kill these bugs or prevent them from releasing virulence factors and all that. So some of them that are under trials, I've just noted them there. Complications, short-term and long-term, as you can see them. Yeah, prevention, the primary pillars for prevention of CAP are smoking cessation, influenza vaccination, pneumococcal vaccination, vaccination from SARS-CoV. For VAP, use of high-flow nasal oxygen or non-invasive ventilation when appropriate to avoid intubation, facilitate RX extubation, and prevent reintubation if possible. In conclusion, community-acquired pneumonia and hospital-acquired pneumonia, major causes of critical illness with a high short and long-term morbidity and mortality. So therefore, a prevention, early recognition, a proper disposition, and appropriate care for this patient group can lower the burden of this kind of illness. So these are my references. Yeah, so I think I can take questions now. Thank you. Over to you, moderator.
Okay, I think Dr. Rasmus is online and he'll be taking on the moderation henceforth. Dr. Rasmus, are you on?
Yes, I am. Thank you very much, Dr. Cornelius, for moderating. And for the first two speakers, Dr. Moduko, this was quite a thorough and broad talk. I know it has generated a lot of questions. So we have a few questions on the chat already. One is regarding gut dysbiosis and gut-lung crosstalk. I think Dr. Arthur Pizera has tried to respond to it regarding the influence of the gut microbiome on lung health. So I guess I don't know, Dr. Joshua Kiptu, might you be satisfied with the response on the chat already? I see as though you opine in that direction. Dr. Kiptu, you can unmute. Okay, I think Dr. Kiptu may not be near his phone right now. So essentially, I guess the question is about. Yes, sir, go ahead.
Yes, no, I think the answer was satisfactory. I think I look forward to, like all of us, the results of the study that is being planned. It's a very interesting topic, and especially the consequence it has in terms of understanding the gut and then the lung health as a combined factor. So thank you.
Yeah, absolutely. Thank you very much. Yeah, the microbiome is becoming quite an important area to look into of late for almost every kind of disease. So there's an axis that a gut influences in one way or another because of all the millions of microbes it has and how it determines the microbiology and health of other organs. So certainly quite a lot of stuff to anticipate out of studies regarding this. So thank you. Do we have any questions coming through for the presenter so far, or he's just presented stuff we know already? Okay, Dr. Cornelius, could we launch the polls for a moment, just in case people don't have questions, we have ours. All right, so we've got,
launched,
yeah, go ahead, Dr. Cornelius, just moderate this part, the questions.
Yeah, please feel free to respond, which I'll take about, since we don't have a lot of time, 2 minutes. These are all questions that coming from the presentation largely. If you've been paying attention, you should be able to answer them. And then we shall have Dr. Charles respond to them and then go to the next presenter. Thank you. All right, 1 minute has passed and I can see responses have started coming in, so keep them coming. Don't try about being wrong. We are all here to learn, so answer the one that you feel is most correct, and then we shall discuss at the end. We have about 1 minute and 50 seconds so far have gone, and the answers are still coming in. We shall maybe give it an extra 30 seconds to get about 25% of the audience. All right, we have more than 25% of the audience now, so I'll stop the poll for the sake of time. Okay, so that's the end of the poll. I'll share the results and Dr. Charles can respond to them as well. So the first question, Charles, was a 65-year-old patient presents with fever, productive cough, dyspnea for 3 days. Chest X-ray shows lobar consolidation in the right lower lobe. Which of the following is the most likely pathogen? 73% of the audience selected strep pneumoniae. What's your take?
Yeah, yes. So I think I agree with the audience because lobar pneumonia is commonly caused by the pneumococcus, streptococcus pneumoniae.
All right, and then which of the following is false? And
So
the patient is hospitalized, and of those 1 in 5 require ICU care. The second option is 40% of hospitalized community-acquired pneumonias have the pathogen identified. And then the third option is 40% of the identified pathogen are viruses. And then the fourth option is Staphylococcus aureus is the most common pathogen. Your take?
yeah, so my take is I will go with Staph aureus is the most common pathogen. I think it is false because the pneumococcus is the most common cause of CAP.
Yeah, so all the other ones are correct. Viruses actually contribute of the 40% of the identified pathogens from pneumonia are actual viruses, and strep pneumoniae is the most common bacteria isolated, which gives about a percentage of about 15%. So there's not much identification of these pathogens, and this is a very huge gap in community-acquired pneumonia patients. And then the third question is a 70-year-old ventilated ICU patient develops fever, leukocytosis, purulent sputum on hospital day 6. Chest X-ray shows new bilateral infiltrates. Which of the following is the most likely causative organism? We have 53% of the audience, unlike the previous question here, it's quite straightforward. 50% of the audience selected Pseudomonas aeruginosa. What's your take, Dr. Charles?
I agree with the 53% that it is Pseudomonas aeruginosa.
All right, and then first question, which of the following doesn't increase the risk of multi-drug resistant pathogens in hospital-acquired pneumonia? First option is hospitalization under 24 hours, prior antibiotic use in the last 90 days, and old age and chemotherapy. 67% of the audience picked hospitalization less than 24 hours. Your take?
I agree with the 67% that it is hospitalization less than 24 hours. So it's.
And then the final question is something that you talked about. Again, the alveolar space is not sterile. It seems to be sort of split, 53% versus 47%. And no one said I'm here to learn. So what's your take?
Yeah, so I think since it is a new concept, my take is a yes, I agree with the 53. But I think maybe we'll need more emphasis on that new concept.
All right. Okay, thank you very much. Over to you, Dr. Rasmus.
All right, thank you very much, Dr. Cornell, for that, and Dr. Muduko. We are moving on to our next segment, and that is going to be presented by a visiting collaborator. So Dr. Lydia Nakinji is an internist. She's known to most of us who've been on Mackay University Hill and Mulago Hill for a while. She's taught many of us. She's an internist and a senior lecturer at Mackay University Department of Medicine, and she practices as a lung specialist. So this evening, she will take us through aspects of bugs, the lung, and the HIV patient. So doctor, kindly share your slides and start right away.
Good evening, colleagues.
Yes,
Can you hear me well?
yes, good evening. We can hear you and see your slides and even your video right away. Thank you.
Okay, thank you very much. And thank you for this opportunity, the team. And I'm very privileged to be here to talk to you about yet another interesting topic. But for the good of the internet, I'll switch it off and just maintain the slides. So this is who I am at the moment. Yeah. So let me switch off the video and proceed with the presentation. Okay. Can you see my presentation in full or it's not in full? Are you able to see my presentation in full?
Yes, now we can see it.
Okay. Yeah, so thank you, the previous presenters. You've actually made my work easy, and especially the discussion on bacterial pneumonia, because it's one of the commonest diseases that we have in HIV. However, we need to know what else it can be when someone has HIV and they have a diseased lung. So we know that lung diseases are the most frequent causes of morbidity and mortality among HIV-infected individuals. And there's been a changing pattern in the epidemiology of these diseases, both before ART and after the ART era. And despite this, still pulmonary TB and bacterial pneumonias are the commonest complications that we see. And all these conditions are as a result of alterations in the immunity of the host, especially as a result of HIV. And in this diagram below, it's just an emphasis on the fact that most of these conditions are as a result of the changes in both the innate and adaptive immune system that result in the different conditions that we see. And just a reminder that the time before ART, we commonly saw these severe infections like pneumocystis jirovecii pneumonia, which is almost fading. But we also saw a lot of mycobacterial infections, severe forms of mycobacterial infections. But now, with the advances in ART, we are beginning to see other infections other than the ones that we previously saw before ART. And right now, we are seeing a lot of, in addition to the TB and pneumonia, we are seeing a lot of COPD, we are seeing a lot of pulmonary hypertension, lung cancers, just to mention. However, most of the risk factors have been mentioned by the previous speaker, but I wanted to highlight the fact that, again, HIV per se is a risk factor for these conditions, but the status of the level of HIV in terms of the viral load also influences how much disease someone would have. And of course, other underlying comorbidities, other medications that someone could be on, especially the ones that are for prophylaxis against opportunistic infections, and of course, socioeconomic status. So this is just a summary of some of the common conditions that we see. And you all agree with me that in our setting, there's nothing that supersedes infections, not only in HIV, but also non-HIV populations. But I wanted us to mainly focus on the increasing frequency of malignancies, not only what we previously saw, that is Kaposi's sarcoma, lymphomas, but also right now bronchogenic carcinomas. We see Castleman's disease. We've also started seeing the side effects of drugs, especially the ART drugs, not only the hypersensitivity reactions, but also as a result of iris, resulting in extensive infiltration. And also, we are beginning to see a lot of other conditions, including COPD, like I earlier said, but also we are getting many patients presenting with hyperreactivity pneumonitis. So HIV, as we all know, this is just a reminder slide that along the spectrum of HIV, we see different disease conditions. And we still have the AIDS-defining illnesses, though their frequency has reduced. But again, pneumonias and TB still happen at all different stages of CD4. But of course, not forgetting that in addition to all these, we still see the atypical TB that could cause some of the severe diseases that you could see in the ICU. But just also to note that among the patients that you receive in the as the critical care team, you'll see these infections as a result of pneumocystis jirovecii. You're going to see severe disease resulting from bacteremia as a result of underlying bacterial pneumonia. You're going to see a lot of malignancies and also other pulmonary viral conditions that were previously seen. So it's very important to look out for them. And of course, on this slide, I still want to emphasize the fact that we now see, because of the increase in the ART availability, we now see other non-infectious complications, which normally occur at any CD4 count. Of course, this has been mentioned earlier by, I think, Charles, the one who presented before me, but I wanted to emphasize the fact that most of these conditions that we see arise from the fact that HIV greatly impacts the innate immunity and adaptive immunity. The innate immunity is very wide, but I wanted us to pay a lot of attention to the alveolar macrophage in the lungs, because this is where most of the problems that result in lung damage arise. Activated macrophages will produce lots of markers or inflammatory markers that result into extensive lung damage, but also other cells of the immune system that really get affected by the HIV. And of course, the direct impact of HIV on the cell-mediated immunity and the humoral immunity. However, there are other mechanisms that really explain why we see a lot of lung damage in HIV. And in this slide, I just wanted to, not really to spend a lot of time on them, but just to highlight some of the mechanisms, because these are the ones that guide the management that the previous speaker has talked about, and even why the patient that was presented earlier presented the way they did present. So of course, we know that HIV will result in, will have extensive systemic inflammation, and we've seen a lot of evidence from studies that associate most of the infections or conditions that are seen in HIV with systemic inflammation. And this systemic inflammation not only affects other parts of the body, but also the lungs, resulting into severe lung damage. And of course, we know there is extensive pulmonary inflammation, especially right now. Studies have shown evidence that the dysfunctional CD8 produce lots of chemokines, cytokines that result in extensive damage to the lungs. For example, the high level of interleukin-6 that comes from the alveolar macrophages has been greatly associated with extensive lung damage. So these are very important because they form the basis of the treatments that we give and the controls that we do when someone gets has HIV and has lung damage. And of course, not forgetting the oxidative stress. We know there are different oxidative stressors that we know that we live with, especially air pollution, smoking, but also we have in HIV, there are lots of abnormal oxidants which result in this lung damage. And usually these do not come down even with the ART. So usually, even when someone has HIV, even with the ART, sometimes they're not protected from the severe lung damage that can occur with HIV. And then, of course, we have right now the area of HIV reservoirs or persistent HIV. And we've always known about the HIV reservoirs, but the lungs have also been identified as one of the sites for HIV reservoirs. And this is an important area to study, how much HIV reservoirs we have in the lungs. And because HIV harbors within the lungs, it eventually results into extensive lung damage. And with this, in presence of other infections or other conditions that could affect the lung, someone ends up with getting extensive lung damage. And of course, the area of the lung microbiome and the gut microbiome still comes in. The previous presenter has had a lot to say about it, but it has been disturbances in the microbiome diversity has been associated with a lot of immune activation and translocation. So we need to pay a lot of attention to the microbiome. And Arthur, I'm looking forward to that study where we can give answers to some of these questions on the microbiome. So what are some of the common conditions that we see? I'm not going to really talk much about the very common ones that have already highlighted in the other graph, but I wanted to pick out some of the conditions that we normally see in our critical care units. And of course, right now we have ART readily available, and many of our patients are going to be started on ART, especially at the time when they are diagnosed. So they have a very high risk of developing the immune reconstitution inflammatory syndrome. And we all know about IRIS, where you have a paradoxical worsening of respiratory condition, which is as a result of ART-induced immune recovery. And I guess many of us have seen IRIS, but one of the IRIS events that we commonly see is the TB IRIS. And I guess in your units, you've seen such patients. And of course, the management is governed by the fact that there is increased inflammation as a result of the IRIS event. So you realize that the kind of management that you give is basically based on the mechanism of the IRIS, but it's one of the conditions that we shall see in HIV. And of course, we cannot conclude a presentation on HIV lung conditions without talking about Mycobacterium tuberculosis as the causative agent for TB. And we know that in a normal individual like you and I, TB is under control through granuloma formation. But in presence of HIV, the granuloma formation is compromised. And because of that, there will be escape of bacilli and multiplication of bacilli to other sites of the body within the lung. And there we now get what we call active TB disease. So HIV does this. So HIV disrupts the control mechanism where TB is well controlled within the granuloma, and then you get active TB disease resulting, and it can go anywhere, but the commonest form is pulmonary TB. But I guess in your units, you've been able to see disseminated TB, even in form of mycobacteremia. You've been able to see extrapulmonary TB in different sites of the body, and you've been able to see and manage sepsis, where you have TB, but with other co-current infections, including severe pneumonia. And we don't only see resistance in the bacteria that have been presented, but also we do see resistance with TB, and it's more common among HIV-infected individuals. So here I just wanted to show some of the patients that we've seen with different forms of TB, and of course the one on my left is a cavity in the left apical area. Then we have a miliary picture. This is all TB that can be seen in HIV, but also extrapulmonary TB, including pleural TB, which could get complicated with empyema-thoracic. And all these can make a patient very, very sick, requiring ICU care. I'm not going to talk about bacterial pneumonia because my previous presenter has talked about it, but here what I wanted to emphasize is that there are now guidelines about the use of pneumococcal vaccines in this population. So don't hesitate to encourage HIV-infected patients, especially in areas where infections of the strep pneumonia is very common, to have these pneumococcal vaccines available. They are available and they should be received by these patients, because the more you get repeated pneumonias, the more lung scarring you get, and as a result, you get long-term complications within the lungs, and including restrictive lung function impairment. So you don't want your patient to be, incapacitated because of poor lung function. So pneumococcal vaccines should be encouraged. I'm about to finish, but before I close the presentation, there are some new areas that have come up, especially the increased prevalence of obstructive airway diseases in HIV, including COPD. I looked at different studies that have spoken the same language about the increased prevalence of COPD. And in this review, there was a significant relationship between HIV and COPD, up to about 3 times. The risk is about 3 times higher in HIV than the non-HIV. And usually we know COPD is a disease where you have a dysfunction or reduced pulmonary function, which is usually associated with age. So the more you age, the less the lung functions. However, with of course age, but of course with other exacerbations that would speed up the reduction in lung function, like smoking, biomass use, pollution, and other factors. However, HIV has been shown to speed up this decline in lung function so fast that we now start to see young patients that have HIV presenting with COPD. And these kind of patients also have lots of exacerbations of COPD. And again, we need to understand the pathophysiology, we need to understand the immunology, and so on. But it has been already shown that HIV is highly associated with COPD. And even if someone is not diagnosed with COPD, they've also shown that HIV positive patients have abnormal spirometry findings. Their parameters on spirometry, even without a diagnosis of COPD, have been abnormal. And especially if someone's HIV is not well controlled. And usually when these patients get COPD, it's usually the severe form, the one which manifests as emphysema. So we need to look out for this among HIV infected patients. And of course, the other area to study is whether ART duration and control of HIV really has an impact on the reduction in lung functions in these people. And of course, related to COPD is asthma. I know this could be a question or a question put out there whether HIV is really an independent contributor to asthma, but studies have shown that HIV-infected patients and even sometimes that if children, not only adults but also children, have a high prevalence of asthma compared to non-HIV positive patients. And this particular study, there was a prevalence up to 16% in HIV compared to only 9% in non-HIV individuals. So what is the connection? We really don't know, but it's postulated that it could be because of the cytokines, the chemokines, especially the suppressive chemokines that really increase the risk of asthma in these patients. But this is an area that one could consider studying. How about pulmonary hypertension? Again, there's been a lot of evidence of association of HIV with pulmonary hypertension. And in one of the studies that I looked at, the prevalence was up to like 0.5%. And of course, in this study also, they showed that even ART did not change the presentation or the fact that someone would develop pulmonary hypertension. And again, people who had lower CD4 or higher viral loads, that is more advanced HIV and uncontrolled HIV, were the ones who are more likely to have pulmonary hypertension. And the histology picture of the pulmonary hypertension that was seen in these patients was similar to what we normally describe as idiopathic pulmonary hypertension. So is it the same spectrum of disease? Is it really an independent, kind of disease that we see in HIV? It's still not known, but pulmonary hypertension should be looked out for among HIV-infected patients. This is my second last slide. Of course, I wanted to briefly talk to you about bronchocarcinomas or lung cancers. Again, studies have shown that there's almost up to 8-fold increase in the incidence of lung cancers in HIV compared to non-HIV. And we now begin to see young populations developing lung malignancies that were previously not seen. So HIV really has an impact. And remember the slides I talked about of how lung damage occurs. So it is through these mechanisms that we think that lung malignancies develop when someone gets HIV. And of course, in these studies, it has also been shown that people who die from lung malignancies, people who have HIV are more likely to die from lung malignancies earlier compared to the ones who may not have HIV. But it's still a question out there that needs to be interrogated in terms of research. I won't talk about LIP because this is mainly with my colleagues in the pediatric unit, but we normally see lungs that are similar to LIP. You've seen more than me, but it causes extensive lymphocytic alveolitis. It's really, really extensive, and when it happens, of course, there's misdiagnosis in adults for other conditions, but somehow it does occur, and usually these patients are diagnosed with interstitial lung disease, but some studies have shown that it's actually LIP that is related to HIV. And then lastly, the COVID-19. Here, I don't have to talk much, but because you all saw what happened, if you got COVID-19 with HIV, the chances of death were higher than those that were not HIV infected. So there is really an association between HIV and SARS-CoV infection with severity and also the outcome. We thank God that COVID-19 is now down, but we should still look out for it, because for those of you who attend the postmortem session, I think we presented 2 patients post the COVID time who have died, including one who was from Masaka, who presented with extensive lung disease, and no one imagined what it was until at autopsy, when we presented this patient as COVID-19 as the primary cause of death. So it is really something that we need to really look out for. So thank you very much, members, and thank you for the opportunity. It was just a brief summary. I didn't want to tire you with the extensive lung conditions that we know. I know we already know them, but I wanted to bring out what is new in this field. Thank you very much. Over to you, Chair.
Thank you very much, Dr. Nachindi. That's excellent. Again, the best chefs usually just serve a little to keep you wanting to come back. So you'll have a lot of questions, a lot of post-talk in you for a lot of the information you have back that you've retained, hopefully also interact with you a lot more in the clinical area for the game that you bring over. So thank you so much for this presentation. I would like to welcome questions. I haven't seen any question in the chat. I will, just before you sit down, Doctor, I'll just ask 2 questions related to immunology of HIV and the lung generally. So would you have some sort of, some sort of magic or standard approach to the likely microbiology of a patient who comes in infected, let's say have pneumonia, and have immunosuppression from HIV versus other forms of immunosuppression, say steroid overuse, cancer, chemotherapy, and so on. That'd be one question. And how does HIV immunosuppression differ from the rest in terms of the susceptibility to bugs? Then 2 would be that would the start of ART completely reverse the chronic inflammatory reaction to HIV, and therefore perhaps not influence how the body would respond to some of these bugs? Because I see that the response perhaps to the common bugs is a little bit more, a little bit different, a little bit more aggressive compared to patients who don't have HIV, who are not immunosuppressed. So I wonder whether just treatment with ART and therefore immune recovery would silence that background inflammatory stress that will influence how the body responds to other bugs. Thank you. Mouthful.
Yeah, that is really extensive, but I think the questions were all related to how different is the HIV immunosuppression different from the other immunosuppressive illnesses in terms of disease, right?
Yes. How? Yeah, exactly.
Yeah. So I didn't really dwell much on that, but what I would like to say is when you have HIV, lots of things happen in your body. And when we say there is immunological improvement in HIV, it means that we have an improvement in, say, CD4s and so on, T cells have improved and so on. However, when you have HIV, even when the cells or the cells of the immune system go up, it doesn't mean that they're all functional. So you may find that in addition to the normal ones or the functional ones, you have a big percentage of cells that are dysfunctional. So when you have dysfunctional cells, they may not do the work that would actually have been done if someone didn't have HIV, and to have lots of those dysfunctional cells of the immune system. So to answer you, yes, HIV causes immunosuppression. However, in addition to the immunosuppression, there's a lot of abnormalities that occur with the cells of the immune system in the presence of HIV. I talked about some dysfunctional CD8 cells that produce cytokines, which is usually in response to HIV antigens. And these produce lots of local pulmonary inflammation. So these cannot be seen in other immunosuppressive conditions, but they're in HIV. So they are there. They are cells of immune suppression. They are cells of the immune system, but they are dysfunctional, and they are producing those bad cytokines or chemicals that are going to cause more damage. So HIV will really cause extensive damage or extensive disease compared to other immunosuppressive illnesses because of that. Thank you. I hope I've tried to answer you.
No, that is brilliant. Thank you. It really opens a lot of it's like a can of worms really, and so there's really a lot of things to think about around HIV. Sure. All right. So Dr. Arthur's hand is up. Dr. Arthur Kwizera, please speak. Unmute and speak.
Sorry,
Okay.
I'd blocked unmuting. Go ahead.
All right. Can you hear me?
Yes, we can hear you. Please proceed.
All right. Yeah. Thank you, Lydia, for that presentation. So I'm just wondering, because you mentioned something very interesting that speaks to some of the work that we're doing. In our clinical practice, obviously in sepsis and critically ill patients, we notice that HIV patients tend to have, well, this is anecdotal, but we've seen some of this work happening elsewhere, that when we're giving fluids to patients, HIV positive patients who have septic shock, they tend to fare quite poorly from a respiratory perspective, in that they need, for lack of a better word, any pressure support, maybe it CPAP, be it high flow, or even intubation, mechanical ventilation. I'm just wondering if the mechanism you have described are also happening because we're talking about the lung. I'm wondering if there was a study in Zambia by Andrews. It was published in JAMA. They did a trial of fluids for patients with septic shock. And in that study, patients who received fluids according to a protocol, surviving sepsis campaign guidelines, fared much worse. And the study actually had to be terminated because there was higher mortality in patients that received crystalloids for septic shock. Now, the question, and this is to all of us, not particularly to Lydia, is whether what Lydia has presented, whether that also, if some of you in practice, when you're giving fluids to HIV positive patients with who become hypotensive, whether this should make us have a rethink, whether we should consider another trial of judicious use of fluids in HIV positive patients who present with septic shock and or respiratory failure, and instead deploy vasopressors a little earlier after giving the first bolus. And so this is just, and anyone can chime in because this is now something of that has become topical. There was another paper that was published by the guys at UVRI, and they actually subcategorized, I think, 4 phenotypes of septic patients, and the HIV population seemed to be associated with the poorer outcomes, especially when they got fluids. So I'm just wondering if some of the molecular biology mechanism you have described play a role in increased capillary permeability in the alveolar space. And this is you might respond to it or not, but just food for thought because this is a clinical observation. And maybe my intensivist colleagues, Erasmus, Cornell, and others here, if that's something that they have observed in HIV positive patients with septic shock requiring and an increased need for respiratory support. Over.
Thank you. Dr. Lydia, do you want to take a shot at it?
Well, thank you. Based on that submission, I guess that is a supplement to what I've presented. So basically, the mechanisms that I've described really answer so many questions when it comes to managing severe lung disease, especially in HIV. And of course, I agree with Arthur that is what we need to do. Should we give, I mean, the guidelines are there, but should we really go by them, given that we now know all these mechanisms that result? So probably we could opt for some other forms of management, maybe give vasopressors and so on, but of course put a balance to the mechanisms that are underlying the lung damage and what the patient may benefit from that. Yeah, but thank you. That is a very good submission, and I guess again, people should consider looking into these mechanisms. Thank you.
All right, thank you. All right, Dr. Cornell, do you have an idea on this in your practice?
Yeah, I think Dr. Lydia answers the question. The impact of critical illness in non-HIV patient just takes a patient to a whole new level of critical illness because of the significantly dysregulated immune system that one would have. Of course, at the capillary level, the impact of all these cytokines and chemokines that have been released is also found to be quite significant. I mean, HIV in and of itself is going to cause a form of a chronic inflammatory state. Now, if you have an acute insult on the body and then you don't factor in the reality that it wasn't just a benign disease that was existing in this individual, but actually an infection that led to a continuous inflammatory process, even at the vascular level, then I think the clinical approach in that case may lead to a clinical trial that is not probably well thought out, like what we saw in Zambia. Basically copy and paste, and then of course you see a huge impact on the organ system that is going to be affected by increased fluid, which is the lungs. So I think the underlying mechanism is actually affecting the vascular permeability, and that will definitely lead to a lot of leakiness. So I totally agree with Dr. Lydia, and I think that mechanism does exist. I do not know if we should test that with fluid, knowing that, but yeah, thank you.
Yeah, thank you very much, Dr. Cornelius. I was just thinking about the morbidity of the patient by the time they turn up. An HIV patient probably has multiple things. You know, generally we've learned in micro that bugs are very selfish. They kind of mark their territory and prevent other bugs from colonizing. But an HIV patient, because of the impaired immunity, is like to be having a polymicrobial kind of infection in them, and what that has in terms of impact on the patient's health itself is difficult to tease out. Yes, HIV patients, I've not necessarily, I do practice targeted resuscitation for patients, and I would not like to pretend that I have observed something very uniquely different, except for the fact that HIV patients generally come when they are very, very sick, and that means so many things can go haywire. I would really love to, that kind of study Dr. Arthur is talking about, where we would be able to match this patient in terms of the, the severity of illness at presentation, and then seeing the specific differences, if you can tease out those differences, targeted personalized resuscitation for each category. That would be quite more useful. Thank you. So over to you, Cornel, for the next polls before we proceed live with the final speaker for the day. You launch the polls.
I'm trying to launch the poll. I'm not sure why it is not. Let me try again. Sorry. Okay. I think I shared the wrong one. Apologies. There are 4 questions. We shall take about 2 minutes to respond to them. I think since we are badly out of time, the third presentation will not have polls so that we can conclude this. We'll take 2 minutes, 20 seconds up so far gone. They are mostly clinical vignettes. Feel free to respond to them, and maybe some of the aspects that Dr. Lydia will emphasize on as she responds to the audience. Okay, 1 minute has passed and no one has yet submitted. The questions are tough, I think, or they are too long. We apologize for both in case they're too tough or too long.
But at least the English, this one is quite clear.
The English is straightforward, yeah.
Grammar is clear, yeah.
Okay, keep the answers coming in. We need maybe about 25% of the audience before we close. Okay, we are going to close soon, so in case you want to submit. Submit as fast as you can. In the next about 9 seconds, we'll be closing the poll. Okay, let me close the poll now. We have about 35% of the audience. All right, so the results, I hope you can see them. So the first question was about an HIV positive patient who comes to the emergency department complaining of shortness of breath, unproductive cough, chest X-ray showing diffuse interstitial infiltrates and oxygen sats at 85% on room air. All the following statements regarding the patient's probable diagnosis are true, except we're looking for the exception to the truth. PJP or PCP is the most common opportunistic infection in AIDS. And then I think let me just go to what the audience selected as the most, as the true exception. Well, an exception to the truth, sorry. That is, anomalous X-ray rules out acute PCP infection. 50% of the audience say this is the exception. Dr. Lydia, your take? Dr. Lydia, in case you're still muted, you're probably still muted in case you're talking. I don't know if Dr. Lydia is with us. Okay, I think, so for the sake of time, I will probably say I do agree with the audience. Pneumochest X-ray does not rule out PCP infection. Then the second question is a 28-year-old HIV positive patient with CD4 count of 150 cells, presents with a chronic cough, weight loss, night sweats, hemoptysis. Chest X-ray shows upper lobar cavitary lesions. Which of the following statements is true regarding tuberculosis in HIV? TB typically presents with upper lobar pneumonia. So 75% of the audience selected option 2, which is extrapulmonary TB, is more common in advanced HIV. Dr. Lydia, in case you're still with us, what's your take on that? The audience selected option B or option 2. Okay, I think Dr. Lydia may not feel that. So let's just go through all the questions, I think. The audience is correct. Typically, cavitation does not occur with significant immunosuppression. And then, of course, the MAN2 option incorrect. Which of the following best explains why HIV patients have high risk of developing COPD compared to general population? And I think this is something that Dr. Lydia talked about. 67% of the audience selected option 2, which says HIV increases chronic systemic inflammation, leading to lung tissue damage, and that is correct. Then the final question is, which of the following is important consideration when treating COPD in an HIV positive patient? And indeed, 64% of the audience selected the correct option, that inhaled corticosteroids should be used cautiously due to increased risk of pneumonia. This also applies to patients who have asthma. So I think it's important that in case a patient has HIV and on steroids, you need to be cautious that they're likely to get infections as well. Thank you. Dr. Rasmus, over to you for the final presenter.
Thank you so much, Dr. Cornelius. Right, so now, just one of the most important aspects of what we're supposed to cover today. Every day we come up with ideas on how to treat these bugs. We are coming up with antibiotics. We are choosing them sometimes randomly, as Dr. Muduko mentioned. Sometimes each one of us has their own idea of how to do it. There's really no antibiogram. And then also the pharmacology of these things may be altered in the critically ill, and therefore the pharmacology of the lung may be altered. The next talk is going to guide us through antimicrobial therapy in lung infections, and Dr. Daniel Chance Mwanda is collaborating with us on this. He is a clinical pharmacist and a Manu fan, but more importantly, a very loved lecturer of pharmacy at Kampala International University, and really been quite a fun guy. You should see him. But more importantly today, we want to share medical aspects that he's going to present to us. So Dr. Mwanda, kindly share your slides.
Thank you so much, Dr. Rasmus. I hope I can be heard and seen from where I am. Good evening to everyone.
Good evening. We can hear you clearly and can see your slides as well.
Okay. Thank you so much. My name is Daniel Chance. I'm a pharmacist and a pharmacologist and also a clinical pharmacist. Yes, I'm a Manu fan, but more importantly, I'm a lecturer of pharmacology and clinical pharmacy. I'm in the mainstream at MAST, where I work as a lecturer there, but also at KIU, where I also do teach pharmacology and clinical pharmacy. So Dr. Erasmus told me to come and talk about antimicrobial therapy of lung infections. Particularly, he told me to focus on HAP and CAP, which have been talked about a lot. So I hope that we shall move a little faster in the interest of time, because it's now coming to about 19:30. So I'll not repeat what has already been talked about because there are some repetitions, but I'll skip them in the interest of time. So all these have been defined. Community-acquired pneumonia, hospital-acquired pneumonia, I'll not go there. Atypical aspiration, pneumonitis, I'll not go back there. Then, just a minute. Yes, antimicrobial resistance, people have been talking about MDR and all that. So we ought probably to know what we mean by MDR. Of course, the definition differs depending on what we are defining. But when we are talking about multi-drug resistant bugs, really we talk about an organism which is non-susceptible to at least one agent in 3 different classes of antimicrobials. And then there's also pan-drug resistant, which does not respond to any. And then we also have extensively drug resistant, which is non-susceptible to at least one agent in all but 2 antimicrobial classes. You should take note of that. Then this has been talked about, so I'll not go back. Risk factors have been mentioned. Using an empiric regimen, this is exactly what my colleague presented, so I'll not go back there. But being that we are discussing antimicrobial chemotherapy, I think one of the limitations we have is distribution of pathogens, like local antibiograms. Currently, we are doing a study in the ICSU of Mbarara Regional Referral Hospital, which we think will help us to give us the output of resistance patterns in the ICU in those particular patients. I saw Dr. Tendo online, Dr. Stephen Tendo, we are working with him. So all these factors have been talked about. I don't want to go back there in the interest of time. But maybe I'll talk about timing of the antibiotics in empiric therapy. It's important that antibiotics are given as soon as possible. And one of the most important considerations is really local susceptibility patterns and also patient individual risk factors. Like mentioned before, if maybe a patient has had a colonization with maybe an MRSA or multi-drug resistant bug, that has to be put into consideration. If the patient is immunocompromised, as we have seen, or a patient has shock who has received antibiotics in the last 90 days and all that, we have to look at it. But evidence has shown that delaying this therapy for more than 48 hours may increase the odds of mortality. If I refer to the patient that we saw earlier, I think they gave antibiotics quickly, but maybe the limitation was, which is a common limitation in our setting, that the cultures really come back a bit late, and that actually always delays the de-escalation, okay? And also, anyway, I'll talk about other things as we go on. So what should the antibiotics cover? If it is empiric, we have already seen which organisms cause, for example, HAP, hospital-acquired pneumonia, and we know staph and Pseudomonas should really be covered. And when you look at the patient that was presented by Dr. Patrick, I think you saw that patient transitioning from CAP to HAP because the patient underwent mechanical ventilation and everything changed. And to my surprise, when they got the isolate, it was Klebsiella. To my surprise, but not also very much to my surprise. If it's Legionella, we know if Roquinol was Izro, if it's an anaerobe, which is quite rare, these are quite rare unless someone has, aspirated. from the GIT, but these are quite rare. But also talk about how we manage all these infections. Then viruses, fungi, not be forgotten. Dr. has just talked about an autopsy of a patient which revealed that COVID-19 was the cause of death. So we should not forget, whereas we are discussing, I'm focusing on antibiotics, but then we need to rule out all these because, for example, if that patient was HIV positive, maybe fungal consideration should also have been put in perspective, okay? So now the antibiotics, if a patient has normal renal function, you realize, for example, in the patient that Dr. Patrick presented, I didn't see anything on trying to see the patient's serum creatinine, which I felt was a major limitation because we are giving, the patient was given cefepime, which actually has been documented to cause neurotoxicity, that is seizures, in patients with renal insufficiency. The patient was also given vancomycin, which we know is quite a nephrotoxic drug, and we have to be mindful of the patient's, renal function. So that was missed, and I think maybe he already told us the patient should rest in peace, but probably I'm not sure whether that could have helped the patient. So if there are no risk factors, we can use PISA, that is piperacillin, azobactam, or cefepime. So I saw cefepime was one of the agents they chose. It actually was not a bad choice based on even what evidence supports. Then levofloxacin in case Legionella is suspected, imipenem, which is normally combined with cilastatin. We know why these two are combined. Imipenem is normally deactivated by renal dipeptidase, which actually both reduces its pharmacokinetics, that is how much reaches the systemic circulation, or its bioavailability, I should say, but also increases its nephrotoxic potential, or meropenem, okay? But we know that if they are extended spectrum beta-lactamases, that's when we consider these carbapenems. But I'll also tell you that ongoing studies are also showing an increased resistance to these carbapenems. Ceftazidime is a third-generation anti-pseudomonal cephalosporin, but unfortunately does not have very good activity on methicillin susceptible staph aureus. So normally it's recommended to be added with vancomycin or even linezolid. Then if a patient has risk factors for MDR gram-negative bacilli, meropenem or imipenem can be used. But because we need to, these carbapenems are in the watch category according to the WEA classification. So we should not just choose them irrationally because we know if they fail, then we're in trouble. So it would be good if we knew probably the prevalence of ESBL, extended spectrum beta-lactamases, so that if it is less than 10%, we still go back to cefepime and piperacillin tazobactam, which we have mentioned before. I already mentioned that imipenem has a higher risk of nephrotoxicity, and if a patient already has renal insufficiency, then we should not prefer imipenem because there's a risk of seizures in those patients. If there is a history of carbapenem-resistant pathogens, and I remember Dr. Cornell talking about it in the patient that Dr. Patrick presented. We have these newer beta-lactamase inhibitors. I think even Dr. Charles talked about them briefly. Ceftazidime, avibactam. Ceftazidime is a third-generation cephalosporin, but this is a slightly newer combination, beta-lactamase inhibitor. And then ceftolozane tazobactam, imipenem cilastatin together with rilebactam, and then meropenem verbobactam, okay? So these therapies are also options, especially for CRE, okay? But if they are not available, then we could consider adding the following drugs. The following drugs are not normally recommended as monotherapy. We know that aminoglycosides do not have a good penetration into the lungs. So remember, one of the considerations in choosing a drug, we look at the pharmacokinetics, we look at the pharmacodynamics. And Tobramycin, which seems to have the best antidomal activity, can be given in addition to maybe the beta-lactam. Colistin, which is a polymyxin, can also be given. Astrionam, levofloxacin, or ciprofloxacin. Okay, all these can be added. We know that the fluoroquinolones are good, have a good penetration into the lungs. However, the resistance is also a bit high, so they cannot be used alone. MRSA, methicillin-resistant Staph aureus, it remains linezolid or vancomycin. Okay, so when do we choose linezolid? When do we choose vancomycin? I'll talk about that in a nutshell. But this is the dosing. The nomogram is available for everyone to check it out. Normally, they give a loading dose to achieve the desired concentration, followed by maintenance doses, and then subsequent intervals. Maybe the alternatives to MRSA, we know that there are several drugs that have activity against MRSA. Not so many, but we know that the glycopeptides, that is vancomycin, telavancin, teicoplanin, and the likes, they have activity against MRSA, but the clinical effectiveness is also differing. But the options can be ceftaroline, which is a 5th generation cephalosporin, which can be given 12 hourly. Tedizolid, this one may have lower cure rates compared to linezolid, so that is why it may not be given as a first-line option. And remember, linezolid is also preferred for patients where maybe the oral route is preferred. I'm going to talk about it shortly. Then telavancin, which is also a glycopeptide. Ceftobiprole, which is a 5th generation. This is mainly approved for non-ventilator hospital-acquired pneumonia. Clindamycin, we know that clindamycin it's active against methicillin-resistant Staph aureus, but it's only recommended if the local antibiogram shows susceptibility. Otherwise, we know that clindamycin is also one of the drugs that actually covers anaerobes, which is an important coverage in aspiration pneumonia, but also we know it's one of the antibiotics that causes a lot of Clostridium difficile associated infection. Okay, so with tailor therapy, as long as we have the results from the microbiology, we de-escalate based on the culture. It's very important to assess the patient within 48 to 72 hours. Most of the time, we expect some improvement, and we look at the clinical response, the results of microbiology, and then the results of microbiology always help us to narrow down the therapy, what we normally call de-escalation, okay? Because when we give broader regimens, there's a higher risk of adverse drug events, Clostridium difficile infection, antimicrobial resistance, and MDR gram-negative infections. We saw that exposure to IV antibiotics prior to getting pneumonia is a risk factor for resistance in itself. So if there is no pathogen identified but the patient is clinically improving, it's recommended to discontinue antibiotic if there is no growth. This is what evidence supports. So what do we use if the pathogen is actually identified? If it is MRSA, it will always be vancomycin or linezolid. There are several factors to consider in choosing vancomycin or linezolid, and I'll talk about them shortly, but the route of administration, if we can get IV access or not, that can determine. Linezolid is very good for oral use. However, studies have not shown significant differences between vancomycin or linezolid. Ceftaroline, I've already talked about this, so let me go. But what about daptomycin? Daptomycin is good against MRSA, but unfortunately, the lung surfactant inactivates it and we cannot use it in treatment of pneumonia. So, what does evidence show? Both linezolid and vancomycin show similar outcomes according to 9 trials that have been on that research that has been done on 9 RCTs, and there were no differences in mortality, clinical response, or MRSA eradication. However, in terms of ADRs, there was also no difference in rates of AKI, thrombocytopenia, or drug discontinuation. We know that when it comes to blood dyscrasias, linezolid actually has more of those blood dyscrasias compared to vancomycin, but the trials do not show any significant difference. When we looked at vancomycin still vis-a-vis linezolid, there was no significant difference in 6-day mortality or ADEs. However, one trial reported more nephrotoxicity with vancomycin, and the difference in vancomycin ADRs could be related to maybe other factors. Studies show that it may not be due to PK and PD issues, because we know that in vancomycin dosing, one of the most important consideration, now maybe to take a little bit deeper, is the area under the curve ratio to the minimum inhibitory concentration, okay? So when they do area under the curve, and they find that okay, there are different ranges, but between 400 and 600 milligrams hour per liter of vancomycin, this is what has shown the best effectiveness, and this correlates with mix of about 1 milligram per mil. So anything that goes above that actually increases the risk of toxicity to vancomycin. And we know that vancomycin can be given either as a continuous infusion or intermittent dosing, but continuous infusions are more easier to monitor and follow up. Intermittent infusions are not used commonly. They can be used in obese patients or patients who have renal insufficiency and all that, but basically if you want to observe the area under the curve, then the continuous might be better for vancomycin dosing. So again, there are some controversial findings here. When mix are higher than 1, there's higher mortality. So that means that we should try to maintain a mix of maybe 1 microgram per mil, because that has shown a better response. So other agents, ceftaroline, prednisolone, telavancin, I've also included them here, even though they are not the first line option. But I think at this level, we have to think a little outside the box, because all these drugs can actually be brought on the market. We can import them if they are not available. So we should consider them for some of our patients. Tigecycline, not recommended because it has actually shown high risk of death, so it's not really recommended. Then ceftobiprole, which is a 5th generation, is approved for CAP, but not VAP, okay? So for methicillin susceptible Staph aureus, we look at the anti-staphylococcal penicillins and nafcillin or cicillin, but cefazolin is normally preferred because it has shown fewer ADRs, that is renal dysfunction and hepatotoxicity, when compared to nafcillin and doxycycline. In polymicrobial infection, cefepime, ceftriaxone are still preferred. I already talked about the limitations of ceftazidime. It does not have good anti-staphylococcal activity. Then for other pathogens, strep, streptococci, and gram-positives, penicillin and ceftriaxone are preferred. And then in other infections, for example, if it is anaerobes, which we expect in aspiration pneumonia, we know that coamoxiclav, that's amoxicillin clavulanic acid, can be very effective. Or moxifloxacin, which is a respiratory fluoroquinolone, or clindamycin, which I talked about earlier, but I said it has a higher risk of Clostridium difficile infection. If the patient is hospitalized, then ampicillin sulbactam is a very good option for that. Yeah, so anaerobic coverage, if it is hospital-acquired pneumonia, of course, imipenem, meropenem, or piperacillin tazobactam can be used. And if the patient is allergic to penicillin, we use a 3rd or 4th or 5th generation cephalosporin together with metronidazole. Yeah. Or carbapenem. We know carbapenems have good anaerobic activity also. And in combinations, metro is preferred because of a lower risk of CDI. So we have to evaluate the patient after 48 to 72 hours. And when we are evaluating, we are looking at the clinical response, We're also looking at risk factors for drug-resistant pathogens. The patient that was presented by Dr. Patrick had a lot of risk factors for drug-resistant pathogens. The patient had high respiratory rates. The patient had been in hospital for more than 5 days. The patient had shock. The patient was immunocompromised. All these, we have to think about them because, as you can see in the last point here, immunocompromised patients, you should consider other causes, okay? So duration is normally typically 7 days, according to recommendations, but in certain patients, like those who are immunocompromised or those who have structural lung diseases, we can consider prolonging it. Procalcitonin is a good biomarker to show to stop antibiotics. So if procalcitonin is declining maybe more than 80% from the peak, then we can consider stopping antibiotics. Procalcitonin is very helpful, usually within about 48 to 72 hours of starting these antibiotics. And also if the patient is hemodynamically stable, clinically improving, able to tolerate oral medication, then we can consider switching them to oral medication based on susceptibility patterns and also penetration of antibiotics into the lungs. Prolonged infusion, I remember Dr. Charles talking about it. If a patient is critically ill, maybe has septic shock, respiratory failure, elevated but susceptible MIC, because we know that the MIC is very important in killing the bacteria. But again, if the MIC is elevated beyond what is recommended, then there's a higher risk of toxicity, just like we saw with vancomycin, that if the MIC is above 1 microgram per mil, then we may not continue with vancomycin, okay? So the agents that we mentioned earlier, PISA, that is piveratin, tazobactam, meropenem, imipenem, cilastatin, and cefepime, can still be used. So this is just a table extracted from up to date, just to show you the different infusion times, 4 hours, 3 to 4 hours, 2 to 3 for different drugs. And then what about aerosolized antibiotics? Again, Dr. Charles talked about it. Now, according to studies, of course, this is still a new area because we know the problem is in the lungs. So it would be good to give an antibiotic that actually reaches the lungs. So studies have been done, especially for colistin, polymyxin, aminoglycosides, that is amikacin. And the evidence currently has shown that there is no clear benefit for using aerosolized antibiotics. For example, studies that have been done have shown that aerosolized antibiotics may increase the antibiotic concentration at the site of infection. But now the evidence is not strong, and actually there is more of ADRs that are being shown. For example, aerosolized amikacin has shown more bronchospasm and occasional cardiac arrest, okay? And then aerosolized cholecystine showed better microbiological eradication rates, but also higher rates of bronchospasm. And in any case, there was similar response between monotherapy and patients who received a combination of IV plus aerosolized colistin. So we have to probably study that area a bit more before we can recommend them. Then, if a patient is allergic to penicillins, we can do aztreonam with linezolid or vancomycin to cover staph. For ESBL, carbapenems remain the mainstay, especially meropenem and imipenem and etapinem for outpatients. For CRE, we still go for the newer beta-lactamase inhibitors, ceftazidime avibactam, meropenem avibactam, imipenem cilastatin relebactam, or cefiderocol. Cefiderocol is also a slightly newer fourth generation cephalosporin that has shown some promising work. So KPC, that is carbapenem, Klebsiella pneumoniae, that is the one that is carbapenem resistant. Still, the drugs that I've listed here, dimavibactam, meropenem avibactam, imipenem cilastatin relebactam, would be good choices. I'm not going so much detail because of time, but here I'm just trying to show some of the beta-lactamases, metallo-beta-lactamases, and all that. But still the option, the first line for this is ceftazidime avibactam. Maybe for metallo-beta-lactamases, ceftazidime avibactam together with aztreonam. But when susceptibility studies show that aztreonam alone is sensitive, then it can actually be used alone. And we also know that ceftazidime and aztreonam, as I'll talk about shortly here, there can be cross hypersensitivity for these drugs. Acinetobacter baumannii, which is quite not very common unless there is contamination, we can use ceftazidime, which is third generation, cefepime, pisa, ampicillin sulbactam, and then sulbactam durlobactam, which is also a very good drug that has a good synergistic potential. Meropenem is another option. Cholecystine is a second line, or polymyxin. And then for CAP, CAP has already been talked about, so I'll not go back into the risk factors. But we know that for community-acquired pneumonia, there's a suspicion of the atypical pathogens, Legionella, Mycoplasma, Chlamydia, especially Chlamydia and Mycoplasma. So in addition to the beta-lactams, such as ceftriaxone or cefotaxime, we can add a macrolide or doxy. Alternatively, we can use a fluoroquinolone alone, okay? So also in our patient that was presented, you saw that they gave cefotaxime together with azithromycin, which was not a bad choice, considering that they were suspecting community-acquired pneumonia. So the fluoroquinolone is an alternative. This can be given alone, especially the respiratory fluoroquinolones, levo, moxi, or gemifloxacin. Beta-lactam plus macrolide usually has better clinical outcomes, and also there are higher Clostridium difficile infection associated with fluoroquinolones. If we suspect Pseudomonas in CAP, there's a complicated regimen here, levo with aztreonam plus an aminoglycoside. We know that aminoglycosides are not very good into penetrating the lungs. However, they can broaden the spectrum of gram-negative microbes, especially the aerobes, okay? And they have very good anti-pseudomonas activity, the best being tobramycin. In the ICU, if we suspect Pseudomonas, of course, we know anti-pseudomonal drugs, pisa, imipenem, meropenem, cefepime, ceftazidime. It's recommended to add a fluoroquinolone, either cipro or levo in this case. And then if there's MISA, still vanco or linezolid, as already discussed. There are also combinations that can be given. For example, vancomycin can be combined with another beta-lactam. This can be synergistic, but not vancomycin and piperacillin tazobactam because of a higher risk of AKI, okay? PISA, that is piperacillin tazobactam with linezolid, can be given safely. And then glucocorticoid therapy, we have some evidence to support use of glucocorticoids in patients who have especially ARDS. So the glucocorticoids are best in patients with respiratory failure or those requiring ventilation. They have shown reduced mortality and reduce the inflammatory response that may cause lung injury. So hydrocortisone 200 milligrams daily for 47 days followed with a TAPA has been recommended. And if a patient is already on a glucocorticoid, it's recommended to continue. However, if a patient has tuberculosis, influenza, hepatitis, or acute herpes viral infections, we ignore. So I'm soon coming to the end. For Pseudomonas aeruginosa pneumoniae, we go for ceftolozane, tazobactam, ceftazidime, avibactam, imipenem, nystatin as monotherapy. Aminoglycosides I've already mentioned are not recommended to be used alone. They're only supposed to be used as add-on therapy. The duration, 7 to 10 days. If a patient has neutropenia, bloodstream infections, or MDR strains, we can do 10 to 21 days, okay? But we can switch to either cipro or levo to complete the course. Again, the inhaled antibiotics, there's little evidence. The Infectious Disease Society of America does not recommend them because of lack of evidence that improves outcomes or survival rates, and also we talked about the bronchospasms. So cholecystine can be given as an adjunct in IV therapy. FDA has only approved it for IV or IM, but not as for nebulizing. If it is mycoplasma, we still know it is the fluoroquinolone, a macrolide, which is of course safer, or doxy. If it is chlamydia, same drugs, but azithromycin is preferred for all these cases. Duration 5 to 7 days. If it is Legionella, still we go for a macrolide or a fluoroquinolone. Duration is still 5 to 7 days, and then pharmacokinetically, we can look at the excretion. Some of them undergo hepatobiliary, others undergo renal excretion. So finally, as I conclude, I brought out part of what we are doing in the ICU, and this is just showing isolates that were got from the trachea aspirate from 49 patients, 24 of them in Barara there. This is a study we did last year between March and November. Out of 24 patients, patients we got from the tracheoaspirate, 24 of them have Klebsiella pneumoniae. And when you look at the susceptibility patterns, you see there is a lot of resistance to some of the drugs. Amoxiclav, the red shows resistance, cotrimoxazole, ceftriaxone, doxy, chloramphenicol, piperacillin, tazobactam, levo, amikacin, even imipinem, which we would think would be good, has shown some resistance. And then when we look at Pseudomonas aeruginosa also, there were equal percentages of resistance to PISA, ceftazidime, which is anti-pseudomonal, imipinem, aztreonam, some to levo, and amikacin, which seem to be performing better. So what is the take home from this discussion? I know it has been the last one and people are already tired. I would like you to help yourself answer the following questions. Which drug is better for MRSA? Is it vancomycin or linezolid? We've already seen that the outcomes are the same, but when do you choose vancomycin? When do you choose linezolid? And I've mentioned that one of the considerations is whether you can get IV access or not, then you would go for linezolid. And if the patient is on other nephrotoxic drugs, then you really have to look at vancomycin critically. What are the monitoring parameters to reduce toxicity? For example, if someone is on vancomycin, you need to know their renal function tests. If someone is on vancomycin for more than 3 days, you have to look at the serum creatinine and see whether it increases by more than 50%, or the creatinine clearance, whether it is also reducing by more than 50% from the baseline. Daptomycin in lung infections, we know what we have mentioned here, the surfactant that inactivates it. What should a clinician consider in choosing a drug for HAP or CAP? What intricacies are involved in vancomycin dosing? The nomogram is available that shows the loading dose and the maintenance dose. And I also mentioned that the best considerate parameter to consider is area under the curve to MIC, okay? That is much better than the trough-guided serum concentration monitoring, because studies have shown that even when the recommended trough levels are received, there are higher risks of vancomycin nephrotoxicity. Then the case presented by Dr. Patrick, I think I kept on talking about it. And we also need to do more research in the field of multi-drug resistant superbugs. MRSA, what is the prevalence? What are the risk factors locally in our settings? We need to have antibiograms, including Pseudomonas. You know, we need to see the local patterns, etiology of these conditions in our setting. And then we also need to compare with our UCG, because I was looking at it, and some of the antibiotics they recommend, honestly, I think have a lot of resistance. So these are some of the references. Up to date was my major source of information, Medscape, and others. Thank you so much for listening. I'll stop it at that. Back to you, Dr. Erasmus.
Thank you so much, Hans. This is lovely. It's always good to have you here. Thank you everyone for holding on up to now. I just want to welcome quick questions to Dr. Chan's talk. Do you have any questions? What challenges do we get when we are dosing these drugs? Maybe Dr. Chance, you could just give us a quick comment on time-dependent versus concentration-dependent killers in terms of the antibiotics we choose and which ones might be preferable in specific conditions.
Okay, thank you so much. So there are antibiotics which are known to have a post-antibiotic effect, like the aminoglycosides. And then, of course, the ones with the post-antibiotic effect are normally can be given once a day. And then there are those which have a concentration-dependent killing, where the MIC is actually very important. For example, if you look at most of the beta-lactam antibiotics, most of them, it is actually concentration-dependent. But when we are choosing these antibiotics, I already talked about the pharmacokinetic consideration. One, I said that there is the MIC, but the MIC alone is not enough because there are some controversies, okay? For example, you can achieve a good MIC, but then you still have to consider the area under the curve in relation to the MIC for some of these antibiotics, like specifically vancomycin. And then the other thing is about penetration into the lungs. That is a very important consideration because, for example, fluoroquinolones can be given once a day. They have good gram-negative coverage, including Pseudomonas, which we have seen one of the most common causative microbes in hospital-acquired pneumonia. However, their penetration into the lungs, they are not so good in acidic environments, is not so good. And also studies have shown that when it comes to being used alone, there's a high risk of resistance. So we do not only look at the time and concentration dependent killing as well as post-antibiotic effect. But in addition to that, we have to go further and look at the area under the curve in relation to the MIC and also ability of the drugs to penetrate the lungs, as well as, of course, other patient factors. That's what I can comment on that. Thank you.
Thank you very much, Dr. All right, any other questions, guys?
Dr. Erasmus, I just want to thank Dr. Chance for doing a tremendous job to explain to us about the antimicrobials. And I think some of the time in clinical practice, it is not uncommon for us to be hesitant to actually initiate patients on medications based on fears, especially the culprit is AKI. And he did a good job to explain to us some of the risks, especially the drugs that we have to be concerned about acute kidney injury. But I just want to add on and supplement that a lot of times some of these fears really are based on evidence that may not be as clear, and sometimes some of the research that we can interpret. So what we apply into antibiotic selection is really something which we have to be considered and develop maybe like protocols to make sure that we are not denying patients some of the medications or the, that they may benefit from. For example, the commonest as vancomycin. So we have this patient, typical patient in the ICU, and as you presented, you may be having a patient who has a polymicrobial infestation, no infection, and from your analysis, they may benefit from not only one antibiotic, maybe 2 or 3, but mostly 2. So if you want to achieve the best coverage, for example, and you maybe want to also make sure that you're not predisposing the patient unnecessarily to clinical risk of any adverse event for the drug. So commonly, if you say a patient is going to be given vancomycin, maybe combined with piperacillin tazobactam, maybe for pseudomonas coverage. So a lot of times you find that we are weighing the clinical risk of, okay, we initiate the patient on it or not. You want to think, should I go ahead? And then you say, oh, there's actually some literature about AKI incidence being high when you combine the two. Now, there is a study that came out, I think, not so long ago, and they're trying to assess the difference between the risk of AKI between combination of vancomycin and then other beta-lactam cephalosporin. And also, the question is that if you combine these two, for example, with PISA, you say piperacillin and then vancomycin plus the other beta-lactam. And the finding was something that leaves you wondering, actually, because the risk of AKI looked to be high among patients who are actually normal renal function at baseline. And then the risk of AKI for those who had pre-standing, renal dysfunction was not as much, So sometimes we have the pseudo AKI scenarios, and because these patients are quite sensitive and their pharmacokinetics have really changed, especially when they come to the ICU, they are quite sensitive, hemodynamically speaking, and then also speaking about their renal functionality and general body functionality. So because of this kind of mix of factors for an ICU patient where the kinetics and dynamics are actually quite interfered with, I think apart from using, following the normal procedure, look at the biograms, look at the local susceptibility patterns, we also have to look at, okay, what are the predisposing factors? So a patient who is on vasopressor, for example, has a higher risk of an AKI, actually, as we saw, and this patient may require vasopressor support. So from my perspective and what Rachans has shared, it is very, very important that, the patient evaluation goes into a sort of like inquiry into what are the possible range of factors. And sometimes it's not one fixed way. It's not cast on a stone. It is really about balancing a number of factors. So that is what I thought I should share. The fear sometimes that we have to allay and, be careful not to deny patients medications when you do the risk-benefit analysis, you realize that no, they would still benefit from medication, but also not making the obvious mistake of initiating medications without understanding the changes, the changes in the patient's dynamics and the kinetics and dynamics as a whole. So that is what I thought I should add. But thank you, Dr. Chandis, for great work, and the team. Thank you.
Lovely, lovely, lovely. Thank you so much, Joshua, for that addition. And very important that we are guided by, the backbone, that's the guidelines, but the reality is that all decisions we take are meant to be, standardized to the patient that's before us. And maybe something that you just highlighted, partly under the pseudo AKI bit, is the aspect that most of these antibodies are organic acids that are also expelled or excreted through the kidney, and they compete with the creatinine. So for most of them, actually, the spike in creatinine, for example, is much earlier than expected for actual nephrotoxicity. And some studies actually have shown that the degree of creatinine rise is much higher than the actual, more accurate rise in accurate tests for kidney injury. For example, the other enzymes that we sometimes test for, like the angle, and we overestimate the degree of AKI in our patients, and maybe that may be something to look into, maybe with more accurate tests to determine what we should be doing for these patients. And certainly the fear for every physician is to cause iatrogenic injury in the name of treating some other problem in a patient who's so sick in the ICU and could die. So thank you very much, Dr. Joshua. Thank you, Dr. Chance, for your presentation. We are well beyond our time, so I would like to invite the mentor of the day just to make some final comments before we conclude. So Dr. Cornelius, over to you, sir.
Thank you, Dr. Rasmus, and everyone who's still here. I'm not going to say much. I'll just say thank you to the team that has presented, and for the lessons that we are taking away from this. I think clinical acumen is very important. Being able to assess who is high risk and who isn't is quite important, and that's where the clinical part comes in. And then, of course, understanding the bugs that are likely to cause pneumonia, both community acquired as well as hospital acquired, is very important. Being able to risk stratify those who are have a high risk for having multi-drug resistant organisms, especially if you've had hospitalization for more than 48 hours, or you've had antibiotics in the last 90 days. These are some of the common things that we find in Uganda. as one of the things that could potentially increase the risk of MDROs. And the diagnostics, of course, have to be based on your clinical acumen. And then, of course, HIV being HIV, it alters significantly the way the innate immune system is going to work, and therefore some of the barriers that you would expect to protect you against the usual organisms can be disorganized, and then, of course, the dysbiosis that may happen as a result of the infection, it can also lead to exposure to even the uncommon bugs that we see in HIV patients. And then, of course, understanding that opportunistic infections that come as a result of the drop in the immunity. And for this, we mostly use the CD4 counts. The lower they are, the more likelihood of having even fungal infections like aspergillus, for example, which we never got into. And then, of course, I think some of the treatments generally for community-acquired pneumonia or what would be hospital-acquired pneumonia, there's a bit of a debate on steroid therapy, and I think that's something we probably not discussed today, but I hope that at some point we shall with the patients, but mostly prednisolone or methylpred the most studied drug in this regard. And then finally, with antimicrobial therapy, I think Dr. Chan's has really elaborated on how to select your antimicrobials, and I think this is very key. Just picking antibiotics randomly without thinking through may lead to misuse of antibiotics. So we need to think through the patient, their clinical status, the likely source of infection risk. In this case, we are thinking of the lungs, but also prior exposure to antibiotics, hospitalization. All these things come in, and this is why the clinical case was actually important for us to put into perspective how to select antimicrobials, including the fact that immunosuppression can change the dynamics in terms of what antibiotics you're going to select in that regard. So I want to thank you all for being part of this, and I want to bid you all good night. And I'll hand over to the moderator to close this up. Thank you.
Thank you very much, Dr. Cornelius, and for those. And definitely, I don't really have anything to add to it. It's just that I've enjoyed the session. And more importantly for me and for everyone is that pneumonia is basically a gateway to sepsis. Unlike every other organ, the heart and the lung are the only organs that actually receive the whole cardiac output, meaning an infection in the lungs is going to bathe every organ, every tissue with those germs, because the blood's going to pass and pick it up. And the diverse microbiology has highlighted diverse possibilities of combinations and response of the body and so on, and also diverse therapies. So the key thing is just to note when to start support, diagnose the patient, treat them specifically as needed, but also prevent. We've heard about the possibility of using vaccines and the like, something that we don't really do so much for our patients. We discharge them home, and some people hope kind of secretly that the patient can come back and pay them a little bit more consultation by getting sick. We need to stop that habit. HIV definitely changes the ball game as we highlighted, and again, we need to watch the pharmacology of microbial choices because patients at different stages respond differently. The big highlight here is daptomycin and some other antibiotics that kind of don't do very well in the environment of the lung. Then those don't penetrate the lung very nicely. So you can actually choose between two different antibiotics. There have been questions about choosing vanco versus saline. And again, if you read about the drug concentrations, it helps you understand the differences. But the beauty of it is that there's really no significant difference so far in terms of clinical outcomes, unless the bug is vancomycin resistant. Thank you so much for being here and waiting all this long. The session has been quite long, and we're hoping that we can make them shorter with time to come. But thank you for your patience, and I would like to bid you farewell after noting that next week, Friday, we shall be here together again for another session helping us understand how to diagnose and determine what exactly is offending a patient. So we shall have another multi-specialist session talking about how to diagnose lung diseases. So tell a colleague, and come in, read up, have more questions to ask in the session. Thank you so much for being here, and have a good night. Have a good weekend. Bye-bye. Till we meet again.